I'm Dr. Bernstein, and we're going to be discussing atrial fibrillation. Afib is a common cause of irregular heart rate, which may or may not be rapid. It's very common in the elderly, and the physiology is easy to understand. The SA node is no longer functioning well in atrial fibrillation, and the atria are fibrillating, that is, quivering or twitching, rather than pulsating. So the AV node is bombarded with this unsteady, irregular signal, and it passes the signal down the His-Purkinje system. The refractory period of the AV node is a limiting step and helps determine the ultimate ventricular depolarization rate, which is often rapid, but doesn't have to be in Afib. It's easily diagnosed on EKG as an irregular, choppy baseline without any discernible P waves, and irregular QRS complexes. These should, in theory, be narrow QRS complexes because the signal does pass through the AV node and the His-Purkinje system, but because the rate may be rapid and the patients are often older and may have a right or left bundle branch block, widened QRSs are also very common. Patients are often asymptomatic. If they develop symptoms, it's usually palpitations and lightheadedness from tachycardia. They may develop angina, which is a sign that they are essentially failing their own internal tachycardia stress test, and they probably have atherosclerotic coronary disease. Some patients may remain permanently in Afib, or they may have recurrent episodes of it interspersed while living most of their life in sinus rhythm. This is known as paroxysmal Afib. The main goals of treatment are to prevent circulatory instability from uncontrolled tachycardia and to prevent stroke. Treatment typically focuses on rate control to prevent tachycardia. Agents that lengthen the refractory period at the AV node will slow the ventricular rate. Most commonly, this would be beta blockers and calcium channel blockers. Digoxin is also used for this purpose sometimes, although less frequently these days. Treatment may also attempt rhythm control to try to restore sinus rhythm, especially in the acute setting if a patient has just developed Afib. For rhythm control, chemical cardioversion can be accomplished typically with class 3 and class 1 antiarrhythmics, such as amiodarone, ibutylide, procainamide, and flecainide. Synchronized electrical cardioversion may also convert patients back to sinus rhythm. The quivering atria mean that blood does not flow linearly through the heart chambers and may instead swirl around in place. This stasis of blood in the atria predisposes to the formation of thrombus. Thus, Afib is an important cause of thromboembolism, usually manifesting as stroke, but emboli may travel anywhere, such as the limbs or viscera. Afib is therefore typically treated with long-term anticoagulation to prevent thromboembolic complications. The risk of stroke from Afib can be estimated using a well-known tool called the CHADS-2 VASC score. You should be aware of this risk estimating tool.